So looking at drugs for treating asthma and other respiratory conditions, one of the big emphases during this discussion is going to be obviously looking at treating asthma, but we're also going to be looking at common drugs utilized to treat some other types of respiratory infections. Now, we obviously spent some time talking about drugs for treating infections, particularly when we went through our chapter on antibiotics, but we're going to look at some other treatments for upper respiratory tract infections, like a lot of drugs that get utilized more to treat symptoms, because as we'll talk about, depending upon the type of a specific pathogen that causes a lot of the respiratory infections, that kind of always dictates what type of medication is used to treat them. So when we look at respiratory infections, so something to note is that specific pathogens can cause various respiratory syndromes. So in particular, a lot of the respiratory infections that we have are going to be caused by viruses. So again, the respiratory infections are going to be classified classified by syndrome. So by that we mean, again, the common cold, bronchitis, pneumonia. So that's what we're going to be looking at as far as like when we're referring to being classified by the syndrome. That's what we're kind of looking at. Most of the common respiratory infections are caused by viruses. So many of your acute respiratory infections are actually viral causes, which means you can't use antibiotics to treat them. So again, it's not uncommon for individuals when they start to experience symptoms of a respiratory infection, they look to get antibiotics because they think it's going to make them better faster. And in case that's not really going to be the case, particularly if it's caused by a virus. So, and many of the more common upper respiratory tract infections that we look at, again, we look at things such as, again, your common cold, your sore throat, sinusitis, those are the types of things that we're going to be looking at. So any type of acute infection of the nose, sinuses, pharynx, larynx are all things that when we look at the upper respiratory tract infections, those are the various areas that get affected by those. And those are the, where a lot of the symptoms of the more common upper respiratory tract infections take place. So in looking at the common cold, so again, most of the individuals, so if you're exposed to someone with a cold, or if you have a weakened immune system, those are various things that could obviously, predispose individuals to getting this. So it's an acute viral infection that causes upper respiratory symptoms. So very common to see. So rhinorrhea is probably the most common symptom, cough and sore throat being along with that. And again, it's going to be spread through droplets. So the droplets that come out as a result of a sneeze or a cough is going to be how the common cold gets spread. Again, obviously a very common infection, particularly during certain months of the year. So again, increased risk factors for, when we look at the increased risk factors for a seasonal common cold is, again, exposure to someone with a cold, a weakened immune system, so someone who's, recovering from surgery, or they're taking certain types of medications that could weaken the immune system. So for instance, if someone's taken like methylprednisolone for a herniated disc, which is a corticosteroid, those have a tendency to cause a weakened immune system. So the treatment, again, for a common cold, rest, over-the-counter medications that can treat the symptoms. And when we talk about medications in this chapter for this purpose, it's important to be able to understand the types of medications and the specific symptoms that they address. Okay, so that's going to be something that we're going to be looking at as we go throughout this chapter, and we're actually going to start that process here. So, for instance, an expectorant, expectorants are used to help to loosen congestion. They actually facilitate coughs. So when you take an expectorant, you actually are it's actually going to cause you to cough, because essentially what's happening with an expectorant is that when someone gets that sort of thickened mucus from the infection, what an expectorant does is it kind of loosens it, and basically by coughing, it allows you to then get rid of the actual mucus. Now that's as opposed to an antitussive. The idea behind an antitussive is that it decreases the sensitivity of the cough receptors. So if you have like a, particularly in individuals that maybe even have like a non-productive cough, the antitussive is used to decrease your cough. Okay, so again, this is the important thing to be looking at with these particular medications is what they do, what particular symptoms, and then we're going to give examples of these medications later on. And then just a general nasal decongestant. So nasal decongestants, what they do is they shrink the nasal blood vessels. So the idea is by shrinking the blood vessels, it creates a situation where you have where you do not have or it'll lessen the congestion that the individual has. So you're actually going to get constriction of the blood vessels in the nose. So these are some examples. So this would be a good table to look at and kind of make note of. So here you see different types of drugs and what they're exactly going to do. Again, not very common as well to take some type of analgesic. So look, showing here acetaminophen. NSAIDs are also utilized as analgesics for colds very commonly as well. You see some other types. So you see the generic name, the drug class, and then some examples. So these would be all good drugs to be aware of and be able to connect them to what they actually do. One thing you do always want to educate your patients on is if they have a cold. So, you're working in a traditional setting and you have a patient that has a cold, if they're taking a multi-symptom type of drug, okay? So for instance, if you look at this chart, you see Tylenol, cold, head congestion, severe. These are it's not uncommon to see this. This will treat multiple things. So you always have to make sure that the patient's aware of the active ingredients in the drug. So for instance, like Sudafed, for instance, is a nasal decongestant. It is pseudoephedrine in it. That's all it is. It doesn't do anything as directly related to. It doesn't have an antitussive in it. It doesn't have an analgesic in it. Sometimes you will have, for instance, nasal decongestants that also do have a pain reliever with them. And the reason why you want to be aware of that is that so they don't go and then take another pain reliever for something else. So that's something to be aware of when you're when you're actually looking at what types of medications they're taking. So that's where the patient education portion of this, because these are all very common over-the-counter drugs that individuals are going to take, that they have to make sure that they're aware of not only the medication, the potential side effects. Again, there's going to be side effects associated with all of these, but to make sure that they know not to take, like for instance, again, another pain reliever if the drug they're taking already has one in it. Okay, now looking at influenza. So influenza is another viral respiratory infection. So some of your symptoms very common with this: fever, coryza, cough, and malaise. So the important thing to note is the kind of the time frame for this particular illness. So the incubation period is about 1 to 4 days when you're looking at influenza. Symptoms will usually subside after 2 to 3 days. So after acute symptoms set in, they do start to subside after 2 to 3 days. Again, people in close contact are typically going to be the ways in which that the flu does tend to spread. Again, it's very contagious. So, for instance, obviously in like sports medicine settings, teammates who are in close contact with each other, very common to have that. And again, obviously things like frequent hand washing, cough etiquette can really help to prevent the spread of this. Now, you may have, when we talk about the symptoms of influenza, some things can last a little bit longer. So again, as we said, after about 2 to 3 days, acute symptoms will subside, but sometimes like fever can go up to 5 days. And sometimes even some of the other symptoms, cough, weakness, sweating, fatigue, actually may persist for several days up to a couple weeks. So one of the things you do want to look at as far as, and this is an important thing to note, is being able to differentiate between influenza and the common cold. Now, the common cold, they both illnesses share common symptoms. However, obviously the common cold is much less severe. There is a table in your textbook, so make note of table 11.2, kind of differentiates between influenza and the common cold. So they talk about like the onset of symptoms, whether there's a fever or not. So for instance, the flu, you're going to have a fever with the flu. It's very rare to have a fever with just a common cold. Most people with that get the common cold don't get fevers. And again, you'll go through the symptoms again. Body aches, typically with a cold, you don't really have body aches, or there might be very mild, whereas with the flu, you have more moderate to severe. So note those differences between the two, the cold and the flu. And again, it's not to say that sometimes symptoms can't cross over, but typically, again, you see common things with cold versus the flu, and as far as how people treat. Now, as far as treatment is concerned, over-the-counter rest, hydration. In the case now with influenza, you want to take an antipyretic to help control the fever. However, you want to avoid aspirin, particularly in patients less than 18 years of age, because you want to guard against Reye syndrome. Now, in addition to the over-the-counter medications, it is recommended, particularly if someone, if it's caught soon enough, that an individual gets treated with an antiviral prescription. So oseltamivir or Tamiflu is, your common antiviral treatment. It's very effective in kind of bringing down your symptoms. It's obviously helpful in preventing hospitalization in vulnerable individuals. It tends to reduce symptoms by about a day, so it doesn't necessarily. It does make you better faster, but not in an overly significant way. But it does help bring your symptoms down, and does help in recovery. And again, it does prevent potential complications. Now, again, most healthy young people aren't going to have severe complications, but it does help. It does help in kind of managing the overall the symptoms. So Tamiflu is usually administered by pill or liquid and is taken twice daily for 5 days. So that's going to be your common treatment for that. Again, note the side effects. Probably the most common side effects for oseltamivir is nausea and vomiting, as far as the side effects for the antiviral medications. And what the antiviral drugs, they're basically classified as neuraminidase inhibitors, which just basically cuts the neuramidic acid into microorganisms, which then kind of allows the body to kind of deal with them more effectively. So again, it's intended to basically, again, reduce symptoms, reduce complications. It can make you a little better faster. Again, most of the time they only find it really only changes it by about a day. Another thing that's really important to note with influenza is influenza vaccines. Very effective. And to kind of note that if you do get an influenza vaccine, it does take about 2 weeks to develop the antibodies. So that's another thing to note about the influenza vaccine. So when you do go and get your flu shot, it does take a little while for you to fully develop the antibodies. So that's why it's important to make sure, and you do have to get a new flu vaccine every season, because the way the flu vaccine is kind of determined is based upon what it's deemed to be the most common strain for that year. Keeping in mind that you could still get the flu, but you're gonna have much less reduced symptoms, and again, that then coupled with the Tamiflu will certainly assist with allowing you to get not have as severe symptoms and to allow you to recover a little faster. Another note as far as again with Tamiflu, we had mentioned that to get the best results from it, you need to be treated within a certain amount of time. So If the symptoms have been not longer than 2 days, the individual is still kind of in that window to where they can get treated very effectively with the Tamiflu. Okay, so turning to sore throat, which is a very common symptom to get when you're looking at a lot of your upper respiratory infections. So when we're talking about sore throat, so we're talking about what we call the medical term tonsillopharyngitis, where essentially you're getting pain in the posterior pharynx or posterior part of the throat with or without swallowing. So the respiratory viruses are the most common cause. So again, you're looking at your rhinovirus, adenovirus, influenza can also cause a sore throat. In some instances, particularly with severe sore throat, getting a throat culture could be important because that could potentially differentiate between viral from bacterial conditions. So, probably one of the more common, bacterial throat infections, what we'd call a streptococcus infection, or, for short, strep throat. Some things that you can kind of differentiate between the two of those. Individuals that have a streptococcal pharyngitis infection, they don't tend to have a lot of your other cold symptoms. So, for instance, someone with a cough, stuffy nose, with a sore throat, more than likely that's going to be a function of a viral infection. So if, however, there is, a person does have very severe sore throat, sometimes even with some other symptoms, it's not a terrible idea, particularly to get a throat culture to determine in the case that an antibiotic, and in many cases a broad spectrum antibiotic many times, will be given to the person to see empirically if it could treat the sore throat. So treatment of a sore throat, supportive care, saltwater gargles, there's various topical anesthetics. So, there's a lot of throat sprays that have lidocaine in them. So those are certainly some things that can be utilized. Some individuals may even get a corticosteroid to reduce inflammation, particularly if there's an airway obstruction. And as we had said, in cases of severe tonsillopharyngitis, an individual may be given a broad spectrum antibiotic like a penicillin or amoxicillin in the case of a possible bacterial infection of the throat. Sinusitis or sinus infection. So acute sinusitis is generally viral. So again, in an individual who is vulnerable, so people with, again, immune system weakness, stress, sleep deprivation, poor nutrition, so individuals that may have just a general upper respiratory tract infection could develop an acute sinusitis. Which again is going to be more common a viral cause. This is probably one of the things that people run to quite quickly to get antibiotics for, and in many cases it's unnecessary and actually doesn't necessarily relieve it any faster. So many times a way to kind of tell is if the sinusitis is prolonged. Because even if you just go off of the mucus, so people always go right away that, oh, well, if the mucus is discolored, you need an antibiotic, and sometimes that is the case, but many times, even in those instances, it resolves many times on its own. So chronic sinusitis is another thing that could develop, and this is usually something due to allergies or environmental irritants. So people that have seasonal allergies, for instance, they can develop a chronic sinusitis, which again, if it does worsen, then there would be a case where other types of medications that could be utilized, like antibiotics, to treat it with. So usually the focus is just going to be on enhancing drainage and clearing up the congestion. So various types of nasal sprays. Now it's important to be able to differentiate, and this is something you're going to want to make note of, that you want to make sure that, for instance, there's various nasal sprays. Phenylephrine is a common nasal spray. That's an alpha adrenergic agonist. That can be administered for the purposes of relieving congestion. And that would be used every 3 hours over a period of a couple days to help in relieving the nasal congestion. There's various types of nasal saline irrigation that can be utilized as well. A neti pot is something that a lot of people with chronic sinusitis will tend to utilize, but the nasal saline irrigation is very good for clearing up congestion, and it's non-habit forming. It doesn't really have a lot of side effects. Again, as you'll see, some of the nasal congestion relievers will have some kind of side effects to them, whereas, for the most part, the saline nasal irrigation just basically will clear out the congestion. Corticosteroid nasal sprays can be used. These are very commonly used for individuals with allergies. They need at least 10 days to be effective, so that you're not going to get immediate relief with the corticosteroid nasal sprays. So in most people that take corticosteroid nasal sprays for allergies will very commonly utilize them regularly throughout the year to make sure that you're getting basically the best benefit from them, because again, it will take a few days. So, for instance, if you get a sinusitis, you start taking corticosteroid nasal spray, you're not going to see the benefit of that for a while. So looking at bronchitis and pneumonia, so acute bronchitis is going to be more is a more common infection in the lower respiratory tract, and usually it will follow an upper respiratory tract infection. So usually that'll come after an upper respiratory tract infection. Many times, though, the pathogen, while we do know that many times is, particularly with acute bronchitis, is viral, you don't usually identify the pathogen. So the most common symptoms are cough, particularly with sputum production. This can occur also with or without fever, so it doesn't necessarily have to have a fever associated with it. So if you have a very productive cough, many times that would tell you that you could possibly have an acute bronchitis. Pneumonia is probably the most common and most frequent lower respiratory tract infection. Pneumonia can be an airborne infection that you get. So basically, when inhaling the infection in the air, particles enter the lungs, and then the infection tends to spread pretty quickly. So this is an airborne infection that will quickly spread into the lower part of the lung, and basically it's going to fill the lung with fluid and mucus. So we've talked a little bit about in pathology kind of some of the things you would notice on a clinical exam with both bronchitis and pneumonia. Now, as far as treatment, most of the treatments rely on supportive care without using antibiotics. So you can potentially incorporate an antiviral therapy, and the antiviral therapy can be used with acyclovir or Zovirax, and many times will be administered to the patient for treatment of a viral bronchitis or pneumonia. If a person does have to go to the hospital, because some individuals may have to get supportive care in a more sterile environment, they'll actually get acyclovir via IV every 8 hours. So that could potentially happen. Although pure viral pneumonia does occur, sometimes superimposed bacterial infections can occur with this. So in the case that does happen, that will require antibiotics. So again, most of the time, most lower respiratory tract infections will be treated with supportive care just to relieve symptoms without using antibiotics. In the case that antibiotics are indicated, that usually means that there's some type of superimposed bacterial infection. So looking at allergic rhinitis and other allergies. So again, allergies are kind of a broad thing. Seasonal allergies to certain food. Everybody's going to have different reactions to things based on the type of allergies they have. Again, it's a very common upper respiratory disorder, particularly when you look at things like seasonal allergies. Again, just briefly to review the pathophysiology of an allergy is, again, it's just an exaggerated immune response. And you have a wide range of responses that the body can have. So obviously, in more severe instances, you go as far as an individual that has, suffers from, gets anaphylaxis, which we all know the respiratory emergencies that are associated with anaphylaxis, and that could also be associated with angioedema or urticaria, which can also happen sort of independently of a full-blown anaphylaxis reaction. When we look generally at particularly the respiratory allergies that can occur, saline rinses, antihistamines, and decongestants, so you need to be familiar with all the different types of medications and where they fall within this. So looking at antihistamines, so antihistamines that we refer to when we're discussing respiratory allergies or just any type of allergies in general, we're usually looking at histamine 1 blockers. There are going to be two categories of histamine 1 blockers that we look at. The first category is your sedating, or what we call first generation antihistamines. So diphenhydramine or Benadryl is really probably your most common first generation antihistamine. Very effective in reducing symptoms. However, they're sedating, which means they cause a lot of drowsiness. So they're not good for, they have very limited use for people, particularly during daytime hours. And actually, the sedating effects actually makes them useful as a sleep aid. So some individuals will actually utilize diphenhydramine as a sleep aid. So that's another thing outside of treating allergies that they'll actually utilize that for. But it also means that they're not really good for active people for daytime use, because of the fact that they have that sedative effect. Typically, a little better use would be with what we call the second generation non-anticholinergic antihistamines. So these drugs are less sedating. They sometimes do cause some drowsiness in people, but it's a little more rare. These have a little bit longer duration of action. As you can see here, 8 to 12 hours. They can have an onset of action of 1 to 3. Claritin or loratadine is one of your more common second generation antihistamines. Another very common one is Allegra, fexofenadine. So again, these are non-sedating. These get used regularly by many people, particularly those with seasonal allergies. And then the last category here, your decongestants. We've kind of discussed these a little bit already. The idea here when using decongestants is that they just reduce that mucous membrane congestion, okay? So you have alpha and beta adrenergic receptor agonists like pseudoephedrine. Also known, the brand name of that is Sudafed. So that's been an over-the-counter drug use for many years. It's now with a little bit of restricted purchase, because individuals, when it was just freely available over the counter, individuals were using it to mass produce methamphetamines. So the other thing is, a lot of times Sudafed could be banned, particularly for certain levels of competition. So we'll talk about that when we talk about drug testing. So pseudoephedrine is very good. It basically produces constriction of the blood vessels in the nasal cavity, so which will help reduce that congestion. Phenylephrine is another nasal mucosa vasoconstrictor. So again, make sure to kind of note. So for instance, phenylephrine can be available via nasal spray form, as well as with oral medication. Again, that is also going to reduce the volume of the nasal mucosa via vasoconstriction. So what that vasoconstriction will do is allow less fluid to leave the blood vessels that enter the nose and throat and sinus linings, and that's going to help decrease some of that inflammation that can occur, and a lot of that mucus production that's going to be caused as well. The thing to be mindful of, anytime you're using particularly any type of nasal spray, again, there's two types of nasal sprays that you can utilize. The one that you can look at is the again that contain phenylephrine. The other one is oxymetazoline. Oxymetazoline is the active ingredient in the nasal spray Afrin. So again, they will both reduce they'll basically cause that vasoconstriction of the arteries. A couple things to note is that when you use nasal sprays, one, repeated high doses could cause ischemia in the nasal cavity, so you want to be careful about that so you can get some ischemic um, changes to the nasal mucosa membrane if you use them too frequently. The other thing is you can get a rebound congestion from them, so a rebound hyperemia. So you need to be careful anytime you're using a topical nasal spray. Yes, they're very effective, but they should only be utilized for they should be utilized for no more than a maximum of 3 days, because of the fact that you can potentially get addicted to them. They could cause the ischemia or even the rebound congestion, all of which can cause issues for the individual. So turning now to asthma, and we've been through a pretty thorough discussion of asthma as what we discussed in the pathology portion. So again, asthma refers to the kind of diffuse airway inflammation that's going to occur, again, through various sort of triggers. So it's going to and ending up in what we would call bronchoconstriction. So by now, if you haven't yet, make sure you review again your signs and symptoms, particularly your red flag signs and symptoms of an asthma attack. So again, that's going to be an important thing. So we've discussed in the pathology portion of the class essentially what's happening physiologically. So again, you should be aware of physiologically what happens with an asthma attack, what are the common signs of symptoms. So, again, obviously things like dyspnea, chest tightness, cough, wheezing, and again, the more severe things. And it's important to make sure that individuals get, you have an emergency protocol in place, that the red flags, particularly for what would be potentially a fatal asthma attack. They're all outlined in your book, and we've talked about them pretty at length in the pathology portion. So you should be aware of all of that. So obviously, we're looking at the pharmacologic treatment when we're looking at asthma. So there's two different types of treatment, generally speaking, when you're talking about asthma. You have your short-acting rescue drugs, so that they will be for the faster treatment, or you have the longer-acting drugs that are for long-term asthma control. So drugs that will look to treat, for instance, the inflammation associated with asthma. So breaking up the short term versus the long term. Okay, so you have your short acting beta agonist, okay, or what are commonly known as your rescue inhalers. So the short acting beta agonists are going to be used as a fast acting to open the airway. Many times they're also used in the prevention of exercise-induced asthma or exercise-induced bronchospasm. So the short-acting beta agonists, also known as the short-acting beta 2 agonists, they are going to be looking to relax the bronchial smooth muscle. So that's essentially what they are. They're bronchodilators. They work to essentially open up the airway, and they start to work within minutes, and they typically will, the effects of them will last anywhere from 2 to 4 hours. Again, these are also very effective in individuals that have exercise-induced asthma, which we'll talk about in a little bit as well, and we actually have talked about. Again, probably the most commonly administered medication here is albuterol, or Proventil is probably one of the more common ones that we see utilized. You also have your anticholinergic drugs. So your anticholinergic medications look to reduce mucus and open the airways by inhibiting what are called muscarinic cholinergic receptors. and they reduce the vagal tone in the airway. So they do work to open the airway, but through a little bit of a different mechanism than short-acting beta agonists work through. And these are also can be utilized with a nebulized albuterol as well. So these can be nebulized and used in a nebulizer for the administration. So they can also be administered with a soft mist inhaler. And there's various other types of ways that they can be administered as well. So this is another type of short-term drug. Oral corticosteroids can be used again, and they could limit the inflammation and the mucus that occurs as well. So these are all different types of short-acting drugs. Again, be familiar with the different types and names of different drugs. I didn't give one with the anticholinergic drugs, but with the anticholinergic drugs, Atrovent is a common anticholinergic drug. That's another drug that can be utilized. That's an anticholinergic. So again, be familiar with drug names as we kind of go through the different categories as well. When we look at long-term medications, so there's the inhaled corticosteroids. And again, they will help in reducing airway responses. And again, this is more of a preventative type of treatment as opposed to something you would be used in someone who is actually experiencing an asthma attack. So again, there's examples of those. Advair, Symbicort are examples of inhaled corticosteroids that can be utilized more for long duration effects. You also have long-acting beta agonists. So we have short-acting beta agonists. We have long-acting beta agonists. So they're also called long-acting beta-2 agonists. Again, they have a duration of bronchodilation of greater than 12 hours after a single dose. Okay, so they're not used as monotherapy for long-term asthma, but they're used in combination with other medications. Again, with the idea of more long-term preventative things in individuals with persistent asthma symptoms. So again, they can be utilized, in a much different fashion. There's others that can be utilized as well. There's mast cell stabilizers. So mast cell stabilizers are an alternative but not preferred medication for the treatment in mild persistent asthma. They can be used as preventative prior to exercise. So the idea behind a mast cell stabilizer is they're just that. They stabilize the mast cells and interfere with chloride channel function, which that helps to in preventing asthma attacks. And then you have your leukotriene modifiers. So leukotriene modifiers, they can be used in certain of conditions associated with an allergic response or asthma. So again, leukotrienes are released from various cells in the immune system. And again, leukotriene modifiers will help modify that inflammatory response. Singulair is a very common leukotriene modifier. And again, that is utilized in the more long-term treatment of asthma as well. So an important thing when managing the care of somebody who has asthma is making sure that their medication protocol is working for them, making sure that they're not having repeat exacerbations. And so in this section of the book, they do talk about the zones of asthma control, which we had talked about as well in the pathology class. So that's another thing you could review with this. They talk about making sure the person finds their personal best peak flow through spirometry. So you should be familiar with the peak flow meter and measuring that with spirometry. So the idea is to get a personal best. So a person will find a personal best through spirometry with their peak flow meter. That tells them that their asthma is under good control, and then basically from there you could kind of determine if the person, there's a protocol you can use. There's what we call the zones of asthma control. They're outlined in the particular text, so make sure to be familiar with those different zones and how and when they get utilized based on the personal best. So, for instance, 80 to 100% of the personal best means that they have good control, no asthma symptoms, they're taking their long-term medications, and they're doing pretty well. Then anything below that, there's 2 levels below that, so you should be familiar with all those. So the idea is having a long-term monitoring plan as part of the management of an individual's asthma. This is going to involve, again, measuring lung function with the spirometer, using pulse ox, and then conducting regular physical exams when needed. The key is making sure to know the difference between caution and when medical action are needed. So again, that's even where you get into those zones of asthma control. So in that yellow zone, that's the caution zone. That's when a person's at 50 to 79% of their personal best peak flow meter reading. That's as opposed to being below 50%, which that's a medical alert, or what we call the red zone. So make sure you're familiar with all of those. But these are all things that can be put into place to prevent any type of major exacerbation and to manage, help the person manage their symptoms better. If a person's having repeat asthma attacks, this is a case where, again, their protocol may need to be reviewed. So again, have a long-term maintenance plan. Again, is this going to involve preventing exacerbations, reducing any impairment, and reducing risk, making sure that there's, everybody should have an action plan in place for managing asthmatic patients. Again, important things like limiting the maximum amount of bronchodilator treatment. So for instance, you can repeat bronchodilator treatments 3 times during the first hour, 1 time per hour thereafterwards. And again, once asthma control is achieved and it has been sustained for greater than 3 months, many times then a prescriber can use patients' information to reassess their medication and even possibly titrate down potentially to maintain control. So they may actually reduce some of the medications if they've been shown that they've been able to sustain things for greater than 3 months. So again, we want to prevent all of these various things, again, to note how well the person's protocol is actually assisting and helping with that. And then looking at preventing exercise-induced asthma or exercise-induced bronchospasm. So remember, a person with asthma can have exercise-induced asthma, but just because you have exercise, so asthma is the actual inflammatory process. So not everybody has that. Some people just have what's called exercise-induced bronchospasm, which has more to do with humidity and temperature within the respiratory tract and the bronchospasm that occurs as a result of that. So pharmacological prevention of exercise-induced asthma. So again, you actually can treat with a short-acting beta agonist before exercising. So about 10 to 15 minutes before, an individual can utilize it as a preventative technique. We've also kind of talked about having the individual going through a vigorous warm-up could also help in preventing an attack while they're actually then doing their activity. We discussed that strategy in the pathology class. Make sure you're familiar with that. You do want to make sure that excessive use of the short-acting beta agonist can diminish the effectiveness, so that's important to note. More than 3 times during practice is concerning. So if a person is consistently utilizing an albuterol inhaler more than 3 times per day, that's usually probably a concern, and they should be reevaluated. So again, you want to make sure that it's not getting utilized excessively, because again, what that's showing is that, again, the asthma symptoms are poorly controlled and there should be a possible change in the protocol. Again, exercise-induced bronchospasm. Again, these are going to be your signs and symptoms, and again, typically this is due to inadequate asthma control. You might want to consider a longer control medication if somebody ends up with a significant history of the exercise-induced bronchospasm. So that's going to be a marker of that. And again, you want to make sure that if there does need to be a change in the lung control medication, that gets monitored. So long-acting beta agonists should only be used for asthma prophylaxis and control. So, and they'll generally be combined with an inhaled corticosteroid if need be. So make sure that you use that. And again, frequent use of that could mask a poorly controlled asthma. So we want to make sure that, again, we want to make sure that an individual is utilizing the drugs appropriately. If something does need to be changed, that would be something that would be done in conjunction, obviously, with the prescriber. So in summary, again, you should be able to recognize your respiratory infections. Again, we've spent a good amount of time in this class reviewing, but again, the information that we discussed in the pathology portion of the class is obviously relevant as well. Again, common conditions can be bacterial or viral. Again, you're only going to utilize an antibiotic where a bacterial infection is present. Again, establish an asthma action plan, so make sure you're familiar with the protocol as far as measuring for spirometry, how to find the personal best, the different zones of asthma control. You should be familiar with all of those and how they get utilized in conjunction with managing the person's asthma. So again, understand the different types of medications and recognize when medical action would be necessary. So those red flags, that coincide with what would be considered a more serious asthma attack. Your book has a red flag section on it on when an asthma attack is starting to progress to more severe symptoms. Make sure you're familiar with that. And again, you do have a very significant role. In my personal experience, I have had some difficult asthma patients that I've had to communicate, more than once sometimes with a physician regarding, managing their asthma symptoms and does something need to change with the medication? Obviously, the physician has the kind of the end say in what gets prescribed, but you're gonna establish that relationship with the physician, and you're gonna be able to give the physician information. Again, you're gonna be seeing the individual more frequently than the physician will. So, again, good documentation, managing symptoms, tracking personal best through spirometry are all things that you're going to want to be able to do. And then being able to give feedback to the physician is going to play a major role in managing the condition. And these are your learning objectives to study for the exam.